We will start in another 2 minutes. Yeah, I think we'll start off the meeting. A very good evening to all the participants who have joined for the webinar, which is being organized by the Spice Route South Asia region in association with the World Obesity Day. World Obesity Day is being celebrated on March 4th every year. And this year we have a theme 8 billion reasons to act on obesity. So we have our own reasons to change the story of obesity because by 2035, half of the world's population, by around 4 billion, are expected to be living with either overweight or obesity. So this is not just an adult issue. Even the childhood obesity is a rapidly rising incident with the rates going sky high among the school age children, increasing fivefold from how it was in 1975. And it is more in the low and the middle income countries. So obesity in childhood often continues into adulthood and increases the risk of serious non-communicable diseases such as diabetes, heart disease, and some cancers. And as far as family physicians are concerned, the obesity per se does not occur in isolation. Poverty, stigma, unequal access to education and healthcare, limited availability of healthy food, and environment that do not support healthy living all shape the risk and outcome across the life course. So almost 3 billion people, including over 400 million school-age children, are living with overweight or obesity. So this makes the topic of obesity to be addressed with utmost importance, and that is why we have chosen this topic for our today's webinar. So we have three speakers lined up for today to give their deliberations. First, I would like to invite Dr. Lijo. Dr. Lijo is a family physician practicing in India. She'll be doing a talk on screening and risk stratification in obesity. She is currently working as a consultant family physician at St. Xavier's Hospital, Tamil Nadu. She completed her MBBS and MD in family medicine from St. John's Hospital and DNB from National Board of Examination. She has extensive clinical experience in clinical care, primary care, emergency medicine, and community health. She's a person with good academic interest, including research and medical education. Over to Lijo to deliver the first talk on risk stratification and screening in obesity. Over to you, Lijo.
Okay. Thank you, sir. Shall I share the screen?
Yes, yes.
Is it visible?
Not yet. Yeah,
Now?
it's coming now.
Okay, thank you. So first of all, thank you and congratulations to the YDM South Asian region for such a wonderful talk which we are arranged for the World Obesity Day, screening and risk stratification in obesity. Without much delay, let's see this thing. One second. It's not moving. Okay. So 8 billion reasons to act on obesity. So this was the theme of this World Obesity Day. So highlights that with a world population of over 8 billion, obesity is a global problem which affects the health system, the economy, and the future generations as a whole, as Dr. Vishnu mentioned. So this is an overview of this today's session. Obesity is a disease in itself and is established risk factor for multiple different conditions. Obesity is defined as abnormal excessive fat accumulation that presents a risk to health as per the WHO. So as per the WHO, the BMI more than 30 kg per meter square as a threshold for obesity. But for our South Asian population, it's 25 kg per meter square is called as obesity. And also according to the Harrison, obesity it's not just mere excess body weight. It emphasizes that muscular individuals may be overweight without increase, even the adiposity increases. Adipose tissue mass is also an important factor for obesity. It's not just the increase in BMI that we'll see in the next sessions. Let's have a quiz time. Participants, kindly put this thing in the comment box, answers. So a 45-year-old man with BMI of 32, waist circumference of 110. What's your interpretation according to the BMI, where he will be placed in the BMI classification, and what's the next step? Any answers? Okay. Yeah, according to the Western classification, it's class 1 obesity. According to Asian, it's class 3. But waist circumference shows central obesity with increased cardiometabolic risk. Correct. So next step is we have to assess the patient properly, order the labs, and it's BMI tells us how much is the problem. But waist circumference tells us where is the problem. Okay. And case 2 is 38-year-old woman with 36 kg per meter square BMI diagnosed with hypertension and type 2 DM. What is the interpretation about EOSS stage? What is EOSS? EOSS is Edmonton Obesity Staging System. According to that, it's good to know as family physicians what is EOSS staging to screen for obesity. Yeah, according to the EOSS stage, this lady will be in EOSS stage 2. Okay, this EOSS will help us in assessing obesity related health risks based on the comorbidities and functional limitations rather than the just BMI. A management plan will be we have to stratify the risk and act accordingly. Okay, so the obesity itself, it's a double burden of malnutrition. Malnutrition doesn't mean only the undernutrition, but it also means obesity also. So global prevalence of obesity has tripled since 1975 because of obesogenic environment. South Asia has emerged as a high acceleration zone where the interplay of genetics, rapid urbanization, industrialized food systems creates an increasing obesogenic environment. Over 650 million adults were obese in 2016, whereas WHO data released 2024 says over 1 billion people from 18 billion, 1 billion worldwide are living with obesity. This includes 879 million adults and 159 children. And also taking the South Asia region per se, 6 to 10% are obese and 20 to 25% are overweight. And there is a increasing, rising trend in children and adolescents. So it's a silent killer, silent impacts, lots of impacts are there. So for the cardiovascular risk, hypertension, diabetes, osteoarthritis, NAFL, OSA, and many. Why? Because factors like poor dietary habits, low physical activity, stress eating, Dr. Parami will be diving into those details, and family eating patterns contribute to weight-related health risk in children and adults. So as family physician, let's go systematic way. Like we'll do history examination as we do for other diseases also, because we consider this also as a disease. So we had to ask for the acute or gradual weight gain, onset, progression, whether any life even correlating with this weight gain, previous weight loss attempts, dietary history with any food habits, like night meals, especially these days, eating behavior, sweetened beverages, eating bakeries, sleep patterns, very important, very important. Sleep duration and quality, sleep hygiene. This also, because of the inadequate sleep, the cortisol levels will be high and the weight gain will go on. In sedentary lifestyle and history of medications are iatrogenic causes like steroids, antiepileptics, antidepressants, antipsychotics, medical conditions like hypothyroidism and many. And very important, screen time, the mobile use, the like sedentary lifestyle, menstrual history, which causes PCOS and all. And coming to family, past medical history, neuropsychiatric, all these things are very important. The substance use itself. In children, history of maternal GDM, PIH, and IUGR is very important to ask. The birth weight of the baby, if the baby is inadequately breastfed, but instead of that, given increased formula feed, weight gain during infancy, toddler, and adolescent age, and developmental history is important. And coming to the physical examination, we had to look for the endocranial facies, dysmorphic features, hirsutism, hyperpigmentation, acanthosis nigricans. Hypothyroidism will cause bradycardia and hypertension, Cushing syndrome, anthropometry, BMI, waist circumference, waist hip ratio. Signs look for the insulin resistance like acanthosis nigricans, skin tags, hypogonadism and hyperandrogenism in girls like hirsutism, acne, hair fall. That's very important. Stretch marks in striae of Cushing syndrome. All these are very important to look for. So coming to the why it's important to screen and stratify obesity. Early identification will help us to catching the risk early, allows preventive measures like lifestyle changes. Prevention of comorbidities will be dealt very fast, and cost effectivity is when we detect early, it's cheaper and more effective when we screening reduces long-term healthcare cost and helps detect obesity before complication develops. Uh, Guides the risk stratification. So in short, screening is the gateway. It identifies who is at risk, prevents disease progression, saves cost, and enables systematic stratification for personalized care. So this is how we go through today's session, screening and risk stratification. I'll just go through the first few only. So step 1 is screen, step 2 stratify, investigate, step 3 tailor the treatment, and then follow up the patient. So we all know BMI. As a patient, we finish the history examination. So in examination, weight in kg and height in meter square. What do you think? If two patients have a BMI of 32, one has the waist circumference of 110 and the other 90 centimeter, which one do you think has a higher cardiometabolic risk? Can you please put it in the comment box? Yeah. Okay. It's obvious that one who is 110 centimeter waist circumference is having the more risk for cardiometabolic risk. Why is it? Because it's very important to have the waist circumference also. We'll come to that. So the Asian BMI and Western BMI, everything is very much different. As we told earlier, obesity for Western population, it's if it is 30, for us it's 25. Why is that? this thing is made, because in Asian population are more tend to get cardiometabolic risk and other complications even with lower BMI. That's what the studies tell. Okay. So waist circumference is paired with BMI. It captures the central obesity. We do position the patient, take from the top of the iliac crest and lower margin of the last palpable rib. Then we have to measure. So increased risk is seen from 94 in male and from 80 on centimeter in female. Waist hip ratio, if it is like one waist circumference divided by hip circumference. Hip circumference, how do we measure? Locate the widest circumference of the buttock, then we divide from waist circumference. So for men, waist circumference more than 0.9, and for females more than 85 indicates increased risk. So very important to know. Skin thickness, good to know. We do measure in triceps, biceps and all, but it's not very specific. Percentiles are there for this. So growth charts in children, very important. BMI plotting is important. Recommended by American Academy of Pediatrics, CDC, IAP, ensures routine surveillance from age 2 onwards. So it's very important for us to children above 95th percentile stratified into high risk groups. Okay, so for metabolic syndromes are more prone for these children. So how do we detect? The detection identifies overweight, then routine surveillance is done quarterly or annually. Categorizing them into the risk groups enables anticipatory guidance, tracks obesity trends. So it should go like national level programs to we had to start screen the children too. So international and South Asian cutoffs are very much different, as we told earlier, because body fat with lower BMI compared to Europeans, like Asians are more prone to have central obesity. These are all risk factors. Studies shows that. So even if we take overweight, obesity, waist circumference, everything is like with lesser cutoffs, it's risk for the Asian population. And the childhood or adolescent overweight and obesity is an increasing trend in South Asian region. Risk factors for obesity related complications. It's if BMI is more than 25 kg, waist hip ratio, all this increased for the risk factors for obesity. Childhood onset, obesity duration, obese with age, family history and comorbidities too. This is one of the important slide, Edmonton Obesity Staging System, EOSS. So we have 5 stages. 0 is no apparent obesity. There is no complications. 2 is subclinical risk factors like borderline hypertension, pre-diabetes, non-alcoholic fatty liver disease. Stage 2, established obesity-related chronic diseases like type 2 DM, obstructive sleep apnea syndrome, polycystic ovarian syndrome, hypertension, osteoarthritis, etc. End organ damage in stage 3 and severe potential disability in stage 4. So how do we approach this? Stage 0, maintain current health function, but like we just given nutritional counseling, physical activity guidance, periodic health screening is very important. Stage 1, like in-depth behavior modification like diet, exercise, stress management, counseling, etc. But monitoring subclinical risk factors is important here. In stage 2, we give medications for comorbidities like diabetes, hypertension, cardiovascular diseases, etc. And stage 3, multidisciplinary management, secondary prevention is made, like intensive medical management for end organ damage and specialized psychological support, vocational physical rehabilitation. Consider we do tell them for bariatric medication, then last for bariatric surgery, etc. And specialized high-level care, it's like highly individual care plans have been made. So we finished with the first step and applied Edmonton obesity staging system. So we know there are n numbers of complications and comorbidities associated with obesity. So studies do tell there is obesity and cardiovascular risk like coronary artery disease, hypertension, heart failure, obesity and cardiomyopathy. Obesity-related GI disorders like from the esophagus like GERD, esophageal ulcers, esophagitis, insulin resistance, pancreatitis, cholecystitis, colorectal cancers, obesity and lung diseases. because lung disease, as we see, obesity reduces the lung compliance, lung volume. So it causes lung disease like OSA, obstructive sleep apnea, obesity, hyperventilation syndrome, and etc. So endocrine consequences of obesity, one of the main characteristic of obesity is the presence of hyperinsulin and insulin resistance, like type 2 diabetes, pre-diabetes, hypothyroidism, hyperuricemia, PCOS, etc. We know metabolic syndrome X and syndrome Z. Syndrome X, abdominal obesity, hypertension, elevated TGL, and high cholesterol, high blood sugar. Syndrome Z plus OSA is syndrome Z. So it's very important. Studies also show insulin resistance and fertility and other complications. Obesity and bone and joint health. Many people, very adults and elderly people, do come to us with a history of osteoarthritis, knee pain, low back pain, degenerative spine disease, osteoporosis, tendinopathies, gout, hyperuricemia, CTS. So there is strong evidence that obesity can increase mechanical load, visceral fat, and bone marrow fat. In addition, obesity is associated with increased adipokinase, increased TNF, etc., low vitamin D. I'm not going into pathophysiology of this, but we have to know and educate our patients about regarding this. Obesity and cutaneous manifestations like acanthosis nigricans, skin tags, they're more prone for the infections, striae, etc. Impact of obesity on reproductive health, both males and females. Females have precocious menarche, oligo and amenorrhea, irregular menstrual cycles, PCOS, infertility, miscarriages, stress incontinence, prolapse. Males also like decrease LH and FSH production, etc. Obesity associated cancers. For every 5 kg per meter square increase in BMI, mortality rate increases by 30%. So obesity also do causes like right from the esophagus, liver, lung, breast cancer, kidney, stomach, etc. So there is strong correlation between obesity and cancer too. It's good to know obesity and associated several syndromes are there, like Prader-Willi syndrome and other syndromes. Nice to know. Obesity and nervous system, ischemic stroke, idiopathic intracranial like a hypertension, Parkinsonism, very important. Obesity and mental health, very important. Depression might cause anxiety, low self-esteem when they compare with other their colleagues or their co-workers, etc. Can cause albuminuria, long-term glomerulonephritis, CKD, and stage renal disease too. So what are the must-do routine investigations in obesity? We finished our history, our examination, our all other specific BMI, waist circumference, waist hip ratio. Must-do investigations are fasting blood sugar, postprandial blood sugar, and HbA1c, fasting lipid profile, LFT, thyroid function test, urea creatinine, uric acid for the complications, urine routine and ECG. Additional assessment we can do for the based on the risk factors. If we are suspecting non-alcoholic fatty liver disease, we can do USG abdomen fibrosis. We can look for the scan, liver elastography, CVD risk for ECG, echo TMT, pro-BNP. If polycystic ovarian syndrome, pelvic ultrasound, testosterone and LH, FSH levels, OSA, musculoskeletal, neurological, this thing we can do accordingly, according to the risk. This is not for all the patients, but the basic investigations, it's very important to do for the obesity related complications. So coming to the final okay, those are coming now. We finished 2 case scenario, small glimpse in the initially. Now third, 12-year-old girl, BMI at 97 percentile. What's your interpretation? How do we manage? Can someone comment in the comment box? Okay, obese. The child is obese according to the pediatric growth charts. And how do we manage? It's by family-based lifestyle intervention, monitor for early metabolic changes, because screening in children is about prevention, catching the risks early before comorbidities develop. Like this child can have PCOS, hypothyroidism, and we do have to counsel the parents for the proper dietary and physical activity, not to have the sedentary lifestyle. All those things we have to educate the child and the parents. So coming to the next. 52-year-old man, BMI 40 kg per meter square with heart failure, hypercapnia and sleep apnea with obesity-related hypoventilation syndrome. What's the interpretation? Where this man will be according to our BMI and all those things. And what's the syndrome called? How we will manage? I have 1 more minute to go. Yeah. Interpretation is like, this okay. So according to the EOSS, Edmonton Obesity Staging System, he is in stage 3. She is stage 3, end organ damage. So management is multidisciplinary care, like bariatric medication and bariatric surgery and treating the comorbidities per se. And here the syndrome is Pickwickian syndrome. Okay, Pickwickian syndrome. It's good to know. Obesity causes name as hyperventilation. I have put the syndrome's name there itself. I wanted to know other syndromes. This thing, OSA, hypercapnia, and restrictive pattern. But this is the one. This right end corner. EOS stage and reassessment. How do we do this reassessment? Stage 0 annually. Stage 1 6 to 12 months. Stage 2 3 to 6 months. Stage 3 and 4, 1 to 3 monthly, we had to screen, we had to reassess the patients. Okay. As a summary, systematic approach for obesity treatment is required. So as a person comes, we had to screen. Screening is not once the disease comes. Before that, we had to screen and educate the persons. Screen every patient, like for BMI, waist circumference, educate them, stratify the risk. We can do Edmonton obesity staging system for the score cardiometabolic risk and all. We can check for that. Next, investigate for comorbidities, as we mentioned. Then intensify tailor the treatment accordingly. Follow up with multidisciplinary system. So these are my references. I know it's been little fast. Had some slides. So we'll help our patients to go from the higher obese condition to normal healthy individuals. Thank you.
Thank you, Dr. Lijo, for giving an elaborate overview on the risk stratification as well as the screening and the various parameters and the scoring systems that we can consider when we are managing or treating obesity. So because as a family physician, understanding the screening as well as the stratifying into the different categories is of utmost importance. So thank you so much for giving an overview. The questions we'll have at the end of the sessions, all the 3 sessions. Now I move on to the second session, which is the behavioral and the psychological aspects of obesity management. It will be dealt with by Dr. Parami Aberatna. Dr. Parami is a lecturer in the Department of Family Medicine at the Faculty of Medicine and Allied Sciences, Rajaratha University of Sri Lanka. She completed her MBBS with academic distinctions and is currently an MCGP trainee while pursuing a Master of Philosophy in Primary Care and Family Medicine, focusing on primary care accessibility in Sri Lanka. Her work focuses on improving access, equity, and quality of primary care services in rural communities. She is also FM 360 coordinator for Spice Route South Asia region. So we have, Dr. Lijo, can you please stop sharing your slides? So thank you. So we'll have the session by Dr. Parami. I'll share the video.
Good evening, everyone. My dear South Asian family doctor family. So I would like to thank the Spice Route Young Doctors Movement of India for organizing this important event webinar on 18 billion reasons to act on obesity on World Obesity Day. And I want to direct my special thanks to Dr. Vishnu for organizing this successful event for South Asian family doctors. Today's my talk will be about beyond the scale, behavioral and psychological foundations of obesity management, a patient-centered approach in family medicine. Obesity is a chronic disease with deep psychological and behavioral roots. It's characterized by complex two-way relationship with mental health. It involves emotional eating, using food to cope with stress, anxiety or sadness, binge eating disorders, and leading to cycle of stigma, low self-esteem and depression that hinders weight loss. According to a recent projection from World Obesity Federation, they predict that by 2030, approximately 1 billion people will be living with obesity worldwide, including 1 in 5 women and 1 in 7 men. In South and Southeast Asian, prevalence of obesity is predicted to be doubled between 2010 and 2030, and they expect about 45 million of South and South Asian children over 5 years to become obese by 2030. So, my talk will be focused on discussing key psychological aspects of obesity, key behavioral aspects of obesity, and sharing few suggestions for family doctors to manage psychological and behavioral aspects related to obesity. This figure shows a model summarizing, moderating, and mediating psychological factors that contribute to relationship between obesity and well-being. At one end, there's obesity, and at the other end, there's common mental health disorders. Mediators in between, like psychological factors like poorer perceived health, negative thoughts, low self-esteem, then social factors like stigma, reduced support, and behavioral factors like diet, exercise, and adherence. What are the key psychological aspects of obesity? We need to discuss about psychological comorbidities. Obesity often coexists with mental health conditions. When you are providing a consultation to a patient coming with obesity, you need to screen for chronic mental health disorders like binge eating disorder, depression and anxiety, and adverse childhood experiences and trauma. Childhood trauma can be the root of the system. Research have shown that people who has a past history of neglect, physical and sexual harassment have high risk for obesity and binge eating disorders in their later life. Also, some children living in chaotic and painful environments use food as the only comfort, accessible comfort for their life. So it becomes a lifelong habit to use food as to regulate their overwhelming emotions coming in their future. Early trauma can permanently alter the hypothalamus-pituitary and adrenaline axis, the body's stress response system, leading to chronically high levels of cortisol, which promote abdominal fat storage. In patients with depression, research have found that they use binge eating to stimulate the brain's reward system, secreting dopamine, providing temporary relief from feelings of hopelessness. Anxiety can lead to emotional eating to soothe the nerve systems. Conversely, the physical health complications and social stigma associated with obesity can trigger or worsen social anxiety and clinical depression. While binge eating disorders and obesity are highly correlated, they are not the same thing. However, their relationship is profound. Frequent binge eating episodes can lead to high calorie intakes, causing weight gain. People with BEDs often attempt restrictive diets to manage their weight. This restriction creates physiological and psychological hunger, which inevitably triggers the next binge, further fueling weight gain and feelings of failure. So, to understand these psychological scenarios, we need to know something about the neurobiology of obesity. So, there are four mechanisms scientists have found that regulate obesity in our biological systems. The first one is about the reward sensitivity. Increased dopamine response to brain's reward system to high calorie foods. Beyond hunger, our biology is wired for pleasure. Modern ultra-processed foods are engineered to bypass the satiety signals and hit the brain's reward center. For some individuals, the brain reward response to food is dampened, leading them to eat more to achieve the same feeling of satisfaction. In some patients, reduced cognitive control occurs due to weakened ability of the prefrontal cortex to control dietary impulses. Stress reactivity is caused by high stress levels activating the amygdala, prompting comfort eating. And also, this is mediated by the stress hormone cortisol. Chronic stress can lead to elevated levels of cortisol, which promotes visceral adiposity and triggers cravings for high sugar, high fat, highly palatable foods. And ultimately, let's discuss about the homeostasis mechanism. This is the feedback loop which regulates the satiety and hunger in our body. This is mediated by two hormones, leptin and ghrelin. Leptin is the satiety hormone produced by fat cells. Its action is to tell that we have enough stored energy and stop eating and burn more, and this signal is sent to brain. But when obese patients have leptin resistance, the brain stops hearing this signal, so it thinks the body is starving when fat stores are high. Ghrelin, on the other hand, the hunger hormone produced in stomach. It spikes before the meals to signal hunger. In many patients who have lost weight, ghrelin levels actually increase and stay high, physically forcing the body to try to regain the lost weight. So, treating the underlying psychological distress is a prerequisite for weight success. So, let's discuss about the key behavioral aspects in regard to obesity. In South Asia, nowadays, traditional diets high in fiber and vegetables are being replaced by high calorie, sugary, and ultra processed foods. Rapid urbanization and the rise of desk based jobs, coupled with limited access to safe, open spaces for physical activity, have increased sedentary time. High screen time, limited outdoor play, and rigorous academic pressures contribute to unhealthy weight even in children. Cultural and social issues limit physical activity, especially for South Asian women. Increased psychological stress linked to rapid urban lifestyle changes contribute to emotional eating behaviors like binge eating disorders. One size does not fit all. In family practice, we see three main phenotypes of eating behaviors. Hungry brain, low satiety, never feels full. Emotional brain, eating in response to negative or positive emotions. Hungry gut, short duration of fullness after a meal. Identifying which brain or gut we are treating allows us to tailor our behavioral interventions rather than giving generic advice. Obesity management means behavioral change. Indeed, for all obesity intervention strategies, including behavioral interventions, medications, and surgery, an individual's commitment to new habits and practices is crucial to success. Thus, in all cases, it is essential to help patients adopt new behaviors like healthy eating, physical activities, medication adherence, protein supplementation following surgery as part of their normal routine. So, what are the management approaches available to address these psychological and behavioral aspects of obesity? As the family doctor, you can choose a good scale to identify negative effects of obesity on quality of life of patients. So I have given some examples scales which have validated in the global context to use for obese patients. So you can use this in regard to the relevance and content. I would like to show one example in regard to obesity adjustment survey. So when you read these questions, you can see the mindset of your patient. how stressful, how distressed are these patients in, how they are socially withdrawn, how are they trying to cope the social stigma and body imperfections and societal pressures directed on them in regard to increased weight gain. One question is, I am so happy that I am too big to exercise as I would like to. Another statement, I do not avoid public situations like going to stores, parties, or the beach because of my present weight. So let's go into the exact management options available for patients with obesity. What is 5A's model of behavioral change? Cultural assumptions and personal experience provide context that forms people's perceptions of their body weight and shape. Some may be unaware that their overweight has placed them at risk of metabolic disease, and some patients may be fixated on an unachievable weight reduction goal. So each of these circumstances represents a barrier for safe and well managed long term weight reduction. A key factor for success in weight management is the setting of realistic, measurable targets for the magnitude and rapidity of weight loss. You first ask for permission. As the doctor, you should be able to prepare to open to hearing the individual's experience in dieting, their fears, which may be based on a history of experiencing stigma and weight shaming. The individual may need to be reassured to learn that weight goals will be tailored to them personally. So they do not need to commit to reaching an ideal weight. So your consultation should aim to set targets on modest weight loss, weight stabilization, or improved physical fitness. If the patient doesn't want to talk about obesity in this consultation, you can keep it for another day. And you should not force the patient to talk about obesity when they are reluctant. You need to assess the patient for staging of the obesity and in regard to investigation of complications and underlying factors leading to obesity. So this need to screen for metabolic disorders, physiological problems like sleep difficulties, overeating, and sedentary lifestyles. You need to screen for mental health disorders like depression, anxiety, stress, and also you need to talk about internalized weight stigma, and these should be acknowledged in this step. Then you can advise the patient regard to communicating the chronic health risk associated with different degrees of overweight and obesity and advising on all relevant treatment options. Recognizing patients' self-perception of their weight may be greater or lesser than obesity staging you have done previously. So the patient need to agree in a goal setting exercise where the individual commits to a course of action and sets realistic targets to achieve and maintain. Targets should be specific, as mentioned in our next slide, smart goal setting, like I will walk for 20 minutes rather than I'll exercise more. Then you need to provide assistance to the patient to help discover and understand factors that have led to weight gain and barriers that may affect overcoming weight loss in the future. Such barriers may be medical problems, psychological issues, or practical problems like transportation systems that are designed for small body sizes. As the clinician, you need to help them work out the solution.
Yes, sorry for the technical glitch. I'll just remove the annotations that was been there.
For these problems. Patients should be encouraged to appreciate that the clinical benefits of weight loss, including effects of comorbidities like cardiovascular diseases and diabetes, actually begin in the range of 5 to 10% of loss of starting body weight. Setting achievable weight loss goals have several important benefits for the doctor as well as the patient with obesity. First, it shifts the focus of weight management from weight loss towards stopping regain. Secondly, once an individual develops confidence on his or her ability to maintain previously lost weight, it becomes possible to set another achievable weight loss goal. So, what happens with motivational interviewing? This is a collaborative goal oriented style of communication. We use the OARS model, OS model. We ask open ended questions like, how would your life change if your knees feel better, rather than asking, you need to lose weight for your knees. When the patient voices the argument for change themselves, a concept called change talk, they are statistically much more likely to follow through than if we provide the rationale for them. Let's move on to smart goal setting. So we discussed about specific setting up specific targets. So these targets should be measurable in weeks or days or kilograms. So these targets should be achievable, like starting small to build self-efficacy. And these should be relevant, focus on non-scale victories like quality of sleep, quality of life with less joint pain rather than number of lost kilograms or improved BMIs. And these smart goals should be set in a time frame. I will try this for the next 2 weeks, and reviewing for another consultation should be done in the future to assess the improvement and setbacks. So, what are the cognitive and behavioral strategies available to address these psychological and behavioral aspects of obesity? We need to encourage self monitoring of obesity among patients. So, they log their food patterns, content types, frequency, like those data, and they will record their physical activity levels, time durations, whether they are moderate or vigorous likewise. So they will self monitor the improvement rather than recording the number of calories. And we try to modify the patient's mindset, patient's environment, food out of sight and out of mind. And we challenge all or nothing thinking through cognitive restructuring. Our job is to help them move towards a growth mindset where a lapse is just a data point to learn from, not a reason to quit. Conclusions and takeaways from today's talk. Validation is the strongest tool in the family doctor's kit. Obesity requires lifelong management, just like hypertension and diabetes. As we conclude today's talk, I would like to remind you that obesity is not about calories or kilograms or BMI. It is a story of human behavior, biology, and psychology. On World Obesity Day, let's us commit not only to act but act with compassion towards obesity. Thank you.
Thank you, Dr. Parami, for that uh, overview on the behavioral and the psychological aspects that we have to consider when we are dealing with management of obesity. So having said that, it's very important what is the right management plan we have to adopt for tackling obesity and what every family physician should know when they are dealing with a patient with obesity. So to deal with that topic, we have Dr. Hina Ali. She is from She's a family physician practicing in Pakistan. Dr. Hina Ali is an instructor at the Family Medicine Department at Aga Khan University, Karachi, Pakistan. She has completed her specialist training FCPS from Pakistan and holds masters in family medicine from University of Edinburgh. She actively contributes to the international journals and is an active member of YDM Pakistan and FM 360 coordinator for Spice Route Pakistan. Over to you, Dr. Hina.
Thank you so much, Dr. Vishnu, and kindly let me know once my screen is visible. Um, is my screen visible and am I
Yes, yes.
audible?
Yes, you are audible, and can you please put it into a slideshow mode?
Yeah, I did. Is it now visible in
Yeah, fine.
slideshow mode?
Okay. Perfect.
Okay, and thank you so much for arranging this session. So my name is Dr. Hina Ali, and so today I will be talking about the right anti-obesity management and what every family physician should know. So the learning objectives is that by the end, all the participants are expected to at least know how to implement evidence-based obesity management and family practice and provide treatment appropriately based on BMI, comorbidities, and patient goals, and recognize timely referral for multidisciplinary care or bariatric surgery wherever it's needed. So that has already been discussed by my colleagues that obesity is a global pandemic and it is closely related to various serious health issues like cardiovascular disease, type 2 diabetes, and certain cancers such as colon cancer, endometrial cancer, and one of the leading preventable causes of death worldwide. Today, over 1 billion people are living with obesity, and it is estimated that by 2035, 1 in 2 people will be either overweight or obese. So the time of action is actually now. So, if we talk about the role of primary care management of weight, it has 5 pillars. First is behavioral counseling, then it's nutritional counseling, physical activity counseling, medicines as needed according to BMI and comorbidities, and referral for bariatric procedures when all these are not effective. So, according to the American Family Physician, all adults over 18 years of age should be screened for obesity either with a BMI or with a waist circumference. And those who are obese should be referred for intensive behavioral intervention. So my colleague has already discussed the 5A framework. So it is a very brief, a very nice framework for brief motivational interviewing. Like when in our clinic we have a patient, we can use this 5A model. So first we ask them permission to discuss weight management. We assess their readiness for change. And we also then advise the risks of excess weight and benefits of modest weight loss. And then agree on realistic treatment strategies and targets. And it's also very important that as family physicians, we then assist them in developing, arranging resources, follow ups, and referrals as needed. So I think lifestyle modification is the most important thing that the family physicians should counsel the patients regarding. So we should ask the patients to follow a very healthy eating pattern, emphasize on increasing whole grains, legumes, nuts, fruits, and vegetables in their diet. Diets such as Mediterranean style, low carb, vegetarian based, or DASH diets are important ways of losing weight. But fat diets, such as the fat diets which are available, they should be discouraged generally. Physical activity is one more thing that we should regularly be counseling our patients regarding. So, more than 150 minutes per week of moderate intensity physical activity, such as brisk walking, should be encouraged. Patients should be advised to do some resistance or strength training whenever appropriate and break up prolonged sedentary time. Like if they have an office job, that after every 30 minutes, they can just go around and have a little walk. So breaking up that prolonged sedentary time is also very important. So according to our American Family Physician, the calorie goal among women can be 1,000 to 1,500 calories per day, and among men can be up from 1,200 to 1,800 calories per day if they're planning on losing weight. And the most important thing is calorie deficit. There should be a calorie deficit of 500 kilocalories or more. That means that the calories burnt should always be more than the calories consumed. And that is how we can actually lose weight and we can counsel our patients on losing weight. So, as I've already mentioned, that more than 150 minutes of moderate intensity activity per week is recommended by the American Family Physician. So, these are some moderate intensity and vigorous intensity activities that we can tell our patients to incorporate in their day-to-day life. And they can gradually build up the minutes. We cannot tell them that they have to start vigorous exercise from day one. They can start from 10 to 15 minutes, and then they can gradually build up the number of minutes. So, weight loss and weight management is always a patient centered care. We can ask the patients to maintain a food diary, record their weight, physical activity, and sleep. So, sleep hygiene is very important for proper weight management. And we need to celebrate weight loss with our patients. Now, on mobile phones, many apps are available. So, patients can be asked to keep their logs in them. So it will be easier for them to bring it to the next follow up, and we can just celebrate the weight loss together. So this is the obesity treatment pyramid. And if you can see that the base of pyramid is mainly formed by lifestyle modification, that is intensive behavioral intervention, nutritional and physical activity. But there are some patients in whom these are not effective enough alone. So patients who have a BMI of more than 30 or BMI of more than 27 with a comorbidity such as diabetes, hypertension, dyslipidemia, they can be given pharmacotherapy. But along with pharmacotherapy, lifestyle modification is still advised to the patient, and with that, we go on and prescribe medicines. So these are some of the FDA approved weight loss drugs. And you can see that initially it was only pills like Orlistat, phentermine, topiramate, then came bupropion, naltrexone, and then came the very successful and very famous injectables such as GLP-1 receptor agonists, liraglutide, semaglutide, tirzepatide. So they are very effective in weight loss and very famous now. So if we talk about Orlistat, it was the first FDA-approved drug for weight loss. So it is actually a lipase inhibitor, and it inhibits the dietary fat absorption. It comes in 60 to 120 milligrams doses. It can be given up to 3 times per day. During or up to 1 hour after meal. But since it decreases fat absorption, its side effects includes oily stools, flatters, fecal urgency, and fecal incontinence. And also we need to prescribe fat-soluble vitamins to our patients as well while they are on Orlistat. These are some other medications that have been FDA approved: naltrexone, bupropion combination, and phentermine and topiramate. They reduce hunger by acting on the brain, but they do have some side effects such as constipation, diarrhea, dizziness. It's mostly GI side effects. So we should be telling the patients about the side effects when we are prescribing the medications. If we talk about the diabetic medications which cause weight loss, we can see that there are some medications which cause a lot of weight loss, like the injectable semaglutide and tirzepatide. Then there is dulaglutide and liraglutide, which also cause significant weight loss. But metformin and DPP-4 inhibitors are weight neutral and they do not cause significant weight loss. So the very famous GLP-1 receptor agonists, which are being used nowadays for weight loss, they include drugs like semaglutide, liraglutide, tirzepatide, and we start with a low dose, continue it for a few weeks, and then gradually increase the dose. And these can be used long term, but we have to tell the patient that when they stop using them, their weight might come back to the original weight. They may regain the weight. So they have to include lifestyle modification in their day-to-day activities. So how do GLP-1 receptor agonists act? They actually improve the satiety, suppress appetite, they decrease glucagon secretion, delay gastric emptying, promote proliferation of beta cells of pancreas, which produce insulin. And that is how they promote weight loss. But GLP-1 receptor agonists also have side effects, and we should tell the patients that they can cause GI disturbances like nausea, diarrhea, vomiting, constipation. They also have a risk of thyroid cancer. So we cannot prescribe them to anyone who has a family history or personal history of thyroid cancer. They can cause skin sagging, wrinkling because of loss of facial fat. AKI, there's a risk of AKI and pancreatitis as well with the use of GLP-1 receptor agonists. So we need to tell these side effects to the patients whenever we are prescribing them these injectables. So I've already discussed these. So this is a summary. These two slides is a short summary of all the weight management drugs that are available, like phentermine, Orlistat, combination of phentermine, topiramate, naltrexone, bupropion, and we can see that GI side effects are the most important side effects of all of them, and they can be, most of them can be used long term, and we have to tell that the patients have to incorporate lifestyle modification together with the drugs. And even the GLP-1 receptor agonists can be given long term, and they also have GI side effects, and as I mentioned, pancreatitis, and they are contraindicated in cases of thyroid cancer, and they can be given long term. So clinical trials have indicated a loss of 15 to 20% weight loss with the use of GLP-1 receptor agonists. If, however, our patient's weight is not reducing with the lifestyle modification and pharmacotherapy alone, or patients in whom a BMI of 40 kg per meter square, or they have a BMI of over 35 kg per meter square with obesity-related comorbidities, we can refer them for bariatric surgery. So there are different types of bariatric surgery, such as sleeve gastrectomy, in which the part of the stomach is removed, and then there's a bypass in which a pouch is developed, and then a bypass is developed direct to the intestine. And then there is a less invasive procedure of gastric banding, in which a band is applied on the top part of the stomach. And all these methods reduce the appetite considerably and can lead to a substantial weight loss. So if patients have a lot of morbid obesity, and they are having a lot of comorbidities, they can be referred for bariatric surgeries. So overall, if we talk about the role of family physician in weight management, the most important thing is early detection, motivation of our patients, awareness, creating awareness about the risks, and also we have to create awareness regarding the benefits of weight loss. And then to keep following our patients, because follow-ups are very important so that we do not lose our patients. And these are the most important roles of family physicians. These are some of my references. And thank you. And you can now enjoy a very healthy meal. And I'm happy to answer any questions. Thank you.
Thank you, Dr. Hina, for that elaborate outline of what are the pharmacological options or the management options that we have in the management of obesity. So we had an extensive discussion on the entire aspects of treatment of obesity, from where we should start or where we should screen, how we should stratify, what are the behavioral and the psychological aspects we should consider, and what are the pharmacotherapy that we can consider in the management of obesity. Now, if you have any questions, it's open for discussion for next 5 minutes. You can either put it up in the chat box, or you can unmute and ask the speakers who is concerned.
Dr. Vishnu, can I ask a question?
Yes, Dr. Gurut, you can proceed.
Okay, so one of the things I've noticed is that patients, when they come to us and approach us for these weight loss medications, it's all over the social media. So sometimes the physicians prefer giving them the oral like metformin, although with few effects on the weight loss, but and then eventually put them on these GLP-1 agonists. But patient always prefers to go straight away on the injectables. So from the speakers, all of them, I just want to know what is their experience and do they give these GLP-1 agonists straight away? Because this is something that is really hyped these days.
Dr. Hina, would you like to take that question?
Yes, so as I've mentioned that there is a BMI cutoff for prescribing GLP-1 receptor agonists. And if a patient is, we have to regularly follow up the patient and give intensive lifestyle and behavioral intervention first. We have to tell them that all medicines come with side effects, and we cannot just go directly to injectables because they have a list of side effects, as we mentioned. So counseling, I think, is the most important thing, and we can start with, and there should be a patient, like a shared decision making with the patient always. So I think the counseling is very important. We have to tell them of the side effects and then go from there. I hope that answers the question.
Yeah. Thank you so much, Dr. Hannah.
I have a question in the chat box, but I'm not exactly clear what the person meant. What is the role of taking performing for obesity? Can you please unmute and ask the question, or can you clarify what you exactly meant? So in the meantime, any other questions anyone want to unmute and ask?
Good evening, sir. I have a question. Can I?
Yeah, but then you
Um,
can.
Good evening, ma'am. So I just want to know that once a particular person has hit their normal range of BMI, is there something called maintenance phase in our set of treatment? Then, if there is so, then what would be monitoring in such patients?
So whom do you want to ask the question? Um, you're asking about maintenance phase in the management of obesity is what you're asking. Can you?
Yes, sir. Because I have learned that such patients will be in long-term follow-up, just like diabetes and hypertension patients. So for me, the question is, once they have hit their normal range of BMI, so for what should be following up them again and again? Like, what will be our, what do you call, checklist that we should look for at each visit?
Dr. Hina or Dr. Lijo, do you want to take that question? Because she's asking that once the patient has attained a target for the management of obesity, how will we proceed with the maintenance? If the patient with multiple comorbidities have we already obese, have attained a target level. So how will you maintain the obesity medications is what she is asking.
No, after,
So as far, yes.
yes, Dr. Hina, you can continue.
Dr. Lijo, you go ahead, please.
No, what was the question? Can you please repeat it after attaining the?
They have attained the main target, and how will you do the maintenance therapy is what she's asking.
Target of what? How much BMI?
Obesity target has been attained with a patient with comorbidities. So after attaining the target BMI or weight, how will you continue the treatment is what the question.
Okay, it's a good question. So the thing is that we had to tailor the treatment for the all other comorbidities. Whatever the comorbidities the patient is having, the person is having, like take it like the hypertension, diabetes, like any other cardio metabolic risk. any risk factors, any complications, comorbidities the patient is having, we had to treat the patient. We had to bring the comorbidities also under control, and we had to help the patient to sustain the dietary habits, and we had to counsel the patient for to sustain the physical activity, whatever is there. We have to help them to sustain that, because there is always, as the previous sessions ma'am mentioned, always there is a they tend to go back to the obese condition. That's what I feel. And Dr. Hina, anything to add on?
Yes, so if someone has attained a normal BMI after being on pharmacotherapy, then a low maintenance dose can be continued. Like for GLP-1 receptor agonists, a low dose can be continued like for a longer period, because trials have shown that once they're off a GLP-1 receptor agonist, they might regain all of the weight. So either they have to be an intensive lifestyle modification, or they have to be on low maintenance. So it depends. If they're able to achieve with lifestyle maintenance alone, then fine, they can be off pharmacotherapy. Otherwise, they have to be on the lowest possible dose and continue following up the clinician. Hope that answers.
That's true. I have seen the patients with very uncontrolled sugars of like sugars of 350, 400 with lifestyle modifications. And with the treatment, they have very much controlled sugars and the obesity and all. That's true. What ma'am mentioned is also we had to give like low dose GLP analogs and all. That's true.
So, and the question is, how is the dose titration of semaglutide, starting as well as and the duration, and how you titrate the dose of semaglutide is the question.
Okay, so shall I answer?
Yeah, Dr. Hina,
Uh,
please go forward.
Okay. So someone also asked what is the BMI cutoff. So anyone over 30 BMI or 27 BMI with comorbidities can be given pharmacotherapy, including GLP-1 receptor agonist. But first we have to start with lifestyle. So diet and exercise comes first, irrespective of the BMI. But once we start semaglutide, it is started at a dose of 0.25 milligrams weekly injection for 4 weeks. Then we gradually up the dose every 4 weeks, like it's 0.25 initially, then 0.5, then 1, then 1.7, then 2.4. And then we maintain on 2.4. And this goes on definitely, indefinitely. It can go on for many years as well, depending on the patient circumstances.
Yeah, I do agree with what Dr. Hina has said. Gradually, we start from 0.25, and as long as the patient tolerates the current dosage, we can continue with 2.4 as the maintenance dose. And if by any chance patient is not tolerating 2.5, 2.4 dose of semaglutide, we may have to step down to 1.7 or even 1. That is for the maintenance of semaglutide therapy. And one question is, can metformin be given to reduce obesity? I think, as she already mentioned in the talk, metformin is a weight neutral drugs which we usually use. So one question, also there is a lot of talk about patients developing visual impairment when on GLP-1 agonist. What is your experience? I personally don't have any of the speakers. If you have any experience regarding that visual impairment, uh, can you please take it?
It's not a usual side effect, but with any drug, any dry eyes and visual impairment can happen, but it's not one of the usual side effects. So pancreatitis, GI disturbances is the most usual side effect we have experienced.
And the question is, patients with osteoarthritis, how to proceed? I think we believe the lifestyle modifications again remains the mainstay of the treatment for a patient with osteoarthritis also. Of course, reducing the weight by 5 to 10% gives an immense relief for the symptoms that the patient has due to osteoarthritis. So weight reduction through lifestyle modification is the mainstay, and if not, I believe have to proceed with the medical therapy. That's what I think. Any take from the speakers? So I think we have Dr. Noordin have asked, but if someone has PCOS, then metformin should be given. Yes, we can give. We have to give metformin.
Because in that case, it helps with the insulin resistance.
Yeah.
But it's not helpful in reducing the weight. It's weight neutral.
So I think we have addressed all the questions. So before we move on to the concluding, if possible, can we all have our cameras on for just a click of for the event? Just for a moment. You can all turn on your cameras. So I'll just give 10 more seconds for everyone to switch on their cameras and I'll have the click. So I'll be clicking in a count of 3, 2, 1. 3, 2, 1. Thank you. So as we mark March 4th as the World Obesity Day, I hope that today's discussion reminds us that obesity is not merely an individual concern, but it is a complex public health challenge that is shaped by social, environmental, and the healthcare systems. So addressing it at the primary care level requires a strong primary care approach, early prevention, and a collaborative action across the communities and health systems. And the Spice Route movement South Asia region continues to advocate for the awareness, the evidence-based interventions, and equitable access to the health environments. So let this be a collective call for action because every life matters and each of us has a role in changing the story of obesity. Thank you, all the speakers. Thank you, all the attendees. We had around 150 attendees, both in Zoom as well as YouTube. So thank you, all of you, for being a part of this webinar and making this